Hello everyone. In this next edition of Spotters and Boosters, I shall discuss few more boosters for enhancement of the knowledge of pharmacology. The answers to the previous SDL6 include question 1, whose answer is succinyl choline is when given with halogen may cause malignant hyperthermia. Question 2, in which congenital myopathy malignant hyperthermia is likely to occur? It is central core disease where there is a susceptibility to malignant hyperthermia as an autosomal dominant trait. Question 3, mention a reversal agent used to terminate muscle relaxant effects of steroid and non-depolarizing drugs, particularly rocuronium and vicuronium. The answer is sugammadex, that is beta-cyclodextrin, that chelates and binds 1:1 equimolar concentration with these agents, and therefore it reduces availability of free drug and a soluble form is formed which is excreted. But this agent may cause answer 4 is the alpha-1 antagonists when used for various conditions may cause dizziness, postural hypotension, particularly in volume-depleted person, and pedal edema because of peripheral muscle dilatation. But they are less seen with highly specific drugs tamsulosin and silodosin, which are used in benign prostatic hyperplasia. An important unique adverse effect is seen with them. That is, they block the dilator muscles in the iris, and therefore tamsulosin silodosin may cause intraoperative floppy iris syndrome, which is characterized by small pupils and billowing eyes during cataract surgery. So patient and doctor who is operating upon should know this. Question 5. Any specific drug useful against chronic tardive dyskinesia? Vilbinazine, a selective inhibitor of presynaptic vesicular monoamine transport inhibitor VMA2, is found to be effective in tardive dyskinesia. We should remember that anticholinergics are not effective and may actually aggravate, and whereas increasing doses of the neuroleptics will do some temporary benefit, but long-term effects will be aggravated. Question 6 is characteristics of the hydrophonium. A number of characteristics are there. It is an alcohol quaternary ammonium derivative that electrostatically and loosely binds to the choline substrate of the active center of the cholinesterase enzyme, and because of this weak non-covalent binding, it is only short-acting inhibitor. It is also short-acting because of it is rapidly eliminated. So it is not the hydrolysis the cause of short action, but it is the rapid renal elimination is the cause. Hydrophonium is used in higher doses to reverse neuromuscular blockade by neuromuscular blocking agents which are used in anesthesia. But the more important is hydrophonium is a drug for diagnosis of myasthenia gravis. A 2 mg dose is injected IV after baseline muscle strength testing. If no improvement occurs after 45 seconds, then additional 8 mg is given, total 10 mg. Patients with myasthenia would show improvement in muscle strength, and that may last for 5 minutes. Hydrophonium is also used for differential diagnosis of cholinergic crisis versus adrenergic versus myasthenia crisis. Excess amount of cholinergic drugs, that is reversible cholinesterase, may also produce the weakness, and if patient receives 1 to 2 mg hydrophonium, this weakness may transiently increase, but if patient has myasthenia, then he will improve. That means if there is an improvement, increasing doses of cholinergic drugs are needed. In past, it was used to terminate paroxysms of supraventricular tachycardia. Now it is rarely used because adenosine and verapamil are available. Question 7 is, how is atracurium inactivated? It is a unique Hoffman's elimination, that is non-enzymatic spontaneous degradation, and esterase hydrolysis also. Which other drug undergoes such spontaneous hydrolysis? One is thalidomide, which is currently used as anti-angiogenetic and anti-tumor drug. It undergoes spontaneous hydrolysis. Cocaine undergoes both spontaneous hydrolysis and tissue esterase inactivation. Question 9. Mention an anti-alimentic drug that acts by inhibiting cholinesterase enzyme in the worms. Answer is pyrethroid. Currently, it is less often used. Question 10 is a patient receives succinylcholine for induction, had prolonged paralysis for about an hour. Normal recovery should be there in 10 minutes. The likely cause is presence of an atypical plasma cholinesterase, that is butyryl cholinesterase, due to allelic variations such as change in the sp and gly polymorphism, which can prolong recovery 3 to 8 times in heterozygotes and up to 60 times in homozygotes. With this, now we begin with the current learning of boosters. Number 1 spot is this is the pathway for entrancing and extensing coagulation cascade, and there are sites where ABCD drugs would act. You have to identify. Now, looking to the sites, A exon intrinsic pathway, C exon common, B exon extrinsic pathway, and D exon common. So the drugs are heparin, low molecular heparin, site A, preferentially heparin. Site B is warfarin, extrinsic pathway. Site C is activated factor 10, that is direct 10 inhibitors. And site D is thrombin, that is direct thrombin inhibitors. Question 2 is the drug neuromuscular blocker was given and clinical monitoring was done during the use by a train of 4 stimuli and double blast strength contraction test. And drug A and drug B, when used separately, showed these pictorials. Train of 4 decremental drug A, and there was also fade in double burst, whereas drug B showed constant reduction in the strength but no fade, and the same was seen with double burst. The nature of drug A and B. Drug A belongs to non-depolarizing competitive skeletal muscle relaxants typified by pancuronium, rocuronium, and D-rocuronium. The fade is seen as a ratio of the fourth response to first response during train of 4 and double burst stimuli. Drug B belongs to depolarizing muscle relaxant typified by succinylcholine. It shows no fade, but strength is reduced. Clinical measurement is always done by using a force transducer that is integrated in anesthesia apparatus. Spot 3. Based on the given graph, mention the order of elimination. Mention 3 drugs that follow such order. Now, if you look at the graph, a constant amount is being eliminated in a given time. So, such a kinetic where constant amount is given in reduced in a given time is zero order kinetic, and a number of drugs over zero order kinetics: ethanol, phenytoin, warfarin, theophylline, imipramine, a few. Spot 4. If you look at this graph, you will find that a constant fraction, about 50%, is eliminated in a given time, unit time. So if we plot log plasma concentration versus time, it will be a straight line. But if we plot a graph between plasma concentration and time, it will. And this curvilinear graph shows that it is first order kinetics, and large number of drugs actually obey this: aminoglycosides, NCRs, and many other drugs. Spot 5 is mention a skeletal muscle relaxant that acts on site X inside the contractile cell, that is skeletal muscle cell. Now here we observe that calcium is being released from sarcoplasmic reticulum, and drug is acting on perhaps on this site. drug X is acting on this site to inhibit the release of calcium from sarcoplasmic reticulum. And there is a receptor, ryanodine receptor present over it, which may be dentulant sodium blocks calcium release from sarcoplasmic reticulum by limiting activation of ryanodine receptor 1 in the membrane. And this agent is used in anesthesia-induced malignant hypertension, neuroleptic malignant syndrome, and is also useful in upper motor spinal spastic disorders, which may occur in multiple sclerosis and spinal cord. Question 6, spot 6 is, this is a cell membrane structure showing movement of sodium ion, and there is a drug that gets ionized, unionized drug goes and that ionized and then acts on the channel, that is sodium channel or part of the receptor. So the nature of it found out. This is a voltage operated sodium channel in excitable cell, say it is a nerve membrane. A drug having a lipophilic moiety permits acid diffusion across phospholipid cell membrane, and it gets ionized in the exoplasm or cytoplasm, and the cationic moiety is able to enter into the channel, that is sodium channel, through its inner gate. At that time it is open. Lidocaine and many other local anesthetics act by this mechanism. A similar mechanism operates in the mechanism of action of anti-epileptic drugs, phenytoin and carbamazepine, and class 1 antiarrhythmic drugs. Spot 8, mention a drug that inhibits step X in the platelet aggregation. This step is the formation of a fibrinogen and glycoprotein 2B3A complex that causes aggregates and clumping of the platelets. So, drug X acts by blocking fibrinogen and von Willebrand factor from binding to activated receptor, thus inhibiting final effector pathway of platelet aggregation. Examples of antagonists are monoclonal derivatives, FCC-MAP and FTFibati, and non-peptide is tyrosine. All these agents are quick-acting, rapidly acting, very useful when given IV during cardiac interventions, percutaneous intervention, and coronary artery bypass grafting. The homework for SDL7 question 1, a drug that inhibits thrombin-mediated platelet activation by targeting protease-activated receptor PAR1, that is the major thrombin receptor on the platelets. Second is, mention a drug that is used as both in vivo and in vitro anticoagulant. Question 3, name a diuretic that has potent uric-uric acid. Question 4, how does dotinurate act in chronic gout? This is a newer drug. Question 5, what do we mean by capacity limited and flow dependent elimination of? Question 6 is, mention an osmotic diuretic that causes glycosuria, that is glucosurasis, natriuresis, but little calciuresis. It is used as an antidiabetic drug. Question 7, mention a drug that increases free water clearance. What could be possible use of it? Question 8, what are the uses of vasopressin analog, desmopressin in particular? Question 9, a diuretic that is used in lithium-induced nephrogenic diabetes insipidus. And 10th is an antibiotic that antagonizes ADH, that is vasopressin.